Half the people who have heart attacks have perfect cholesterol. I've held coronary arteries in my hands during bypass surgery, arteries that belong to patients whose cholesterol test said excellent for 10 years straight. And when I touched those arteries with my forceps, they didn't flex like healthy vessels. They crunched like stepping on gravel. That's calcium. That's years of particles piling into the wall while the standard test saw nothing. I'm going to show you the 3 blood tests that actually predict whether you'll survive the next 5 years. Tests your doctor has probably never ordered, tests that could have saved hundreds of my patients, tests that cost less than dinner, but could tell you right now if there's a time bomb in your chest. And I need to warn you, what I'm about to reveal should make you furious because these tests exist. They're cheap, they're accurate, and the medical system has been ignoring them for decades while people pass away with perfect cholesterol numbers. The cholesterol test your doctor runs is from 1985. It measures the wrong thing, and it misses half the people who are about to have heart attacks. By the end of this video, you'll know the 3 tests that actually matter, you'll know the exact words to say to your doctor, you'll know the numbers you're looking for, and you'll understand why a man named Harold almost died at 62 with perfect cholesterol, and how 3 simple blood tests could have saved him 5 years of damage. Stay with me because this starts with Harold. Harold was 62 years old, a retired engineer from Minneapolis, meticulous about everything. His garage was organized by tool size, his finances tracked to the penny, and his health managed with the same precision. Every year, Harold went to his doctor. Every year, he got his cholesterol checked, and every year he got the same result. Total cholesterol 185, LDL 92, HDL 58, triglycerides 118. Textbook perfect. His doctor would look at the numbers, look at Harold, and say the same thing every visit. Whatever you're doing, keep doing it. Harold did keep doing it. He walked 3 miles every morning. He ate oatmeal for breakfast. He limited red meat. He took a fish oil capsule every night. He didn't smoke. He drank 1 glass of wine on Saturdays. By every standard measure, Harold was the picture of cardiovascular health. His wife, Sarah, noticed he seemed more tired than usual in the months before it happened. He'd come back from his walks needing to sit down. He blamed it on age. What Harold didn't know, what his doctor didn't know, what the yearly cholesterol test was completely blind to, was what was happening inside his coronary arteries. On a Tuesday morning in March, Sarah heard a sound she will never forget. The thud of her husband's body hitting the kitchen floor. Sarah was in the bedroom. By the time she reached him, his lips were blue. Sarah told me later she couldn't find a pulse, just nothing. She pressed on his chest for 7 minutes waiting for the ambulance. 7 minutes of not knowing if the man she'd loved for 40 years was already gone. The paramedics shocked his heart 3 times before they got a rhythm. The ER team rushed him to the catheterization lab. They found his left anterior descending artery, the widowmaker, 95% blocked. They placed a stent. They saved his life, barely. 3 days later, I opened Harold's chest for bypass surgery to address the other blockages, and I saw what the cholesterol test had missed. His left anterior descending artery was yellow, thick. When I touched it with my forceps, it didn't flex. It crunched like gravel under my fingers. That's calcium. That's plaque deposits. That's a decade of particles piling into the arterial wall. And his cholesterol test said excellent every single year while this was building. Harold's father had a heart attack at 58, his grandfather at 61. Harold thought he'd beaten the family curse by managing his cholesterol. He hadn't beaten anything. He'd just been measuring the wrong number. His cardiologist finally ran the tests that should have been run 5 years earlier. ApoB, 142 mg/dl, should be under 90. Oxidized LDL, 78 UL, should be under 60. Lipoprotein A, 186 nmol, should be under 75. 3 tests, 3 numbers screaming danger, 3 warnings that were never heard because nobody ran them. I want you to do something right now. Think about your last cholesterol test. Do you remember your LDL number? Most people do. Now ask yourself, do you know your ApoB? Do you know your oxidized LDL? Do you know your lipoprotein A? If you don't know those numbers, and most people don't, you're missing the tests that actually matter. Write this down. ApoB, oxidized LDL, lipoprotein a. These are the 3 tests you're going to request at your next appointment. Now, let me explain exactly what each test measures and why it's more important than the cholesterol number you've been obsessing over for decades. The first test is Apolipoprotein B, also called ApoB. This is the single most important blood test for predicting heart attack risk. More important than LDL, more important than total cholesterol, more important than any number you've ever been given. Here's why. Heart attacks are caused by plaque. Plaque is built by particles, specifically particles that carry cholesterol into your artery walls. Your standard LDL test measures how much cholesterol is inside those particles. But here's what nobody tells you. It's not the cholesterol that causes the damage. It's the particles themselves. Think of it this way. Imagine a highway. The particles are trucks. The cholesterol is the cargo. Your standard LDL test measures the total weight of cargo on the highway, but it doesn't count how many trucks are on the road. Here's the problem. Some people have a few big trucks carrying a lot of cargo. Other people have many small trucks carrying the same total cargo. The total cargo is identical. The standard test shows the same number, but the person with more trucks has far more risk. Why? Because it's the trucks that crash into the artery wall, not the cargo. Each particle that penetrates the wall starts the process that builds plaque. More particles, more crashes, more plaque, more heart attacks. ApoB counts the trucks. Every single atherogenic particle in your blood has exactly one ApoB molecule on its surface. Every LDL particle, every VLDL particle, every IDL particle, exactly one, no exceptions. When you measure ApoB, you're counting every single particle that can cause heart disease, directly, accurately, no estimation, no calculation, just a count. Researchers looked at 9 major studies comparing ApoB to LDL cholesterol. 9 studies. Every single one showed the same thing. ApoB predicts heart attacks better than LDL. 9 out of 9, not 8, not most, every single one. And your doctor is still measuring LDL. The Cardiology study followed young adults for 25 years. People with high ApoB but normal LDL had a 55% higher risk of developing coronary artery disease. People with high LDL but normal ApoB had no increased risk. Read that again. Normal LDL didn't protect them. High ApoB killed them. Harold's LDL was 92. His doctor said, excellent. His ApoB was a 142. His arteries were filling with plaque while his doctor smiled and said, keep doing what you're doing. This is called discordance, when LDL and ApoB don't match. And it happens in about 20% of people, 1 in 5. 1 in 5 people with normal LDL cholesterol have elevated ApoB. That's millions of people walking around thinking they're protected, thinking their numbers are fine, thinking they've beaten heart disease, while particles are piling into their artery walls, building the plaques that will kill them. What should your ApoB be? For general prevention, you want under 90 mg/dl. If you have diabetes, high blood pressure, or family history of heart disease, you want under 80 mg/dl. If you've already had a heart attack or have known heart disease, you want under 70 mg/dl. Some cardiologists now push for under 60. The European Society of Cardiology states clearly that ApoB is a more accurate marker of cardiovascular risk than LDL cholesterol. The Canadian Cardiovascular Society recommends ApoB over LDL as the primary metric. Yet most doctors in America still don't order it. At your next appointment, say these exact words, I'd like to add an ApoB test to my lipid panel. It measures atherogenic particle number, which the European guidelines now consider more accurate than LDL cholesterol for assessing cardiovascular risk. That's the language, those specific words, because the system responds to clinical terminology. The test costs about $20 to $30. Most insurance covers it. Your doctor just has to check a box. One checkbox. That's all that separates you from knowing whether your particle count is killing you. The second test is oxidized LDL. Here's something your doctor has never explained. Normal LDL doesn't cause heart attacks. Let me say that again because it contradicts everything you've been told. Normal LDL particles circulate through your blood. They deliver cholesterol to cells that need it. They get cleared by your liver. They're just delivery trucks doing their job. They're not supposed to hurt you. But when LDL oxidizes, everything changes. Think of oxidation as rusting. Your LDL particles get exposed to free radicals in your bloodstream. The fats inside the particle become rancid. The proteins become damaged. The particle becomes oxidized LDL. And oxidized LDL is a completely different beast. Your immune system recognizes oxidized LDL as a foreign invader. It thinks it's a pathogen, a bacterium, something dangerous that needs to be destroyed. So your immune system attacks it. White blood cells called macrophages enter your artery wall. They find the oxidized LDL particles that have penetrated the endothelium and they eat them. They engulf them. They try to destroy them, but they can't process all that oxidized cholesterol. They become overwhelmed. They swell up. They transform into foam cells, fat-filled immune cells that become the foundation of plaque. This is how atherosclerosis begins, not from cholesterol, from oxidized cholesterol. I've seen these foam cells during surgery. When you cut into a diseased artery, you can see the yellow streaks, the fatty deposits. That's foam cells. That's your immune system trying to clean up oxidized LDL and failing. That's the beginning of the blockage that will kill you. And here's what makes this critical. Your standard LDL test has no idea whether your LDL is oxidized or not. It just measures the total amount. It doesn't measure whether that LDL is healthy and functional or rusted and inflammatory. You could have an LDL of 95, your doctor says perfect, but if 40% of those particles are oxidized, you're building plaque right now. Your arteries are inflamed right now. Your immune system is creating foam cells right now. The standard test is blind to this. People with high oxidized LDL are 4 times more likely to have heart attacks than people with low oxidized LDL. 4 times. One study found that oxidized LDL had 76% sensitivity for identifying coronary artery disease versus standard risk assessment at 20% sensitivity. Oxidized LDL was nearly 4 times better at finding disease. Harold's oxidized LDL was 78 UL, should have been under 60. His LDL particles weren't just numerous. They were damaged, inflamed, actively recruiting macrophages, actively building foam cells, actively creating the plaque that blocked his widowmaker artery. The standard test saw none of this. Now I need you to do something. Go to your kitchen right now. Open your pantry. Look at the ingredient list on your crackers, your salad dressing, your granola bars, your cooking spray. If you see soybean oil, canola oil, corn oil, sunflower oil, vegetable oil, those are oxidizing your LDL right now. Every day you eat these, you're rusting your cholesterol from the inside out. Your doctor has never told you this. The food industry doesn't want you to know, but those oils are in 80% of packaged foods, and they're turning your healthy LDL into inflammatory time bombs. If you found seed oils in your pantry, and most people do, that's not your fault. The food industry put them there. But now you know, and now you can remove them tonight before they oxidize another LDL particle. These oils are high in omega-6 fatty acids. When you eat them, they get incorporated into your LDL particles. They make those particles more likely to oxidize. It's not just seed oils. Sugar and refined carbohydrates create oxidative stress. High blood sugar damages LDL particles directly. It's why diabetics have such high rates of heart disease. Even when their cholesterol looks fine, their LDL is oxidized. Smoking. Every cigarette floods your body with free radicals that attack LDL particles. Chronic inflammation. Any source of inflammation in your body increases oxidative stress and damages LDL. What protects against oxidation? Antioxidants from whole foods, berries, dark leafy greens, extra virgin olive oil, pomegranates. These compounds neutralize free radicals before they can damage your LDL. Omega-3 fatty acids, fish oil, fatty fish, these get incorporated into your LDL particles and make them resistant to oxidation. CoQ10, this antioxidant rides on your LDL particles and protects them. Here's something important. Statin drugs deplete CoQ10. So while statins lower your LDL number, they might be leaving the remaining particles more vulnerable to oxidation. Another reason the number alone doesn't tell the whole story. What should your oxidized LDL be? Under 60 UL is considered optimal. 60 to 80 UL is borderline and needs attention. Over 80 UL is high and requires intervention. At your next appointment, say these exact words. I'd like to test my oxidized LDL levels. This measures whether my LDL particles are damaged and pro-inflammatory, which standard LDL testing doesn't capture. The test costs about $40 to $60. It's available at most major labs. Your doctor just needs to order it. The third test is Lipoprotein A, also called Lp(a). This is the test that could have saved Harold's father and his grandfather, and nearly Harold himself. Lipoprotein A is a genetic variant of LDL. It's determined almost entirely by your genes. It doesn't respond to diet. It doesn't respond to exercise. It barely responds to statins. And if you have high levels, your risk of heart attack is 2 to 3 times higher than someone with normal levels. The American Heart Association calls Lp(a) a genetically determined, causal, and prevalent risk factor for atherosclerotic cardiovascular disease. Causal. That means it doesn't just correlate with heart disease, it causes it. Here's how. Lp(a) particles are similar to LDL, but with an extra protein attached called Apolipoprotein A. This extra protein does 2 terrible things. First, it carries oxidized phospholipids. These are inflammatory molecules. They accelerate plaque formation. Lp(a) is essentially a delivery vehicle for inflammation. It brings the fire directly to your artery walls. Second, it interferes with clot dissolution. When your body forms a clot, it also has mechanisms to break that clot down. Lp(a) looks similar to a protein called plasminogen that's involved in clot breakdown. It competes with plasminogen. It blocks clot dissolution. It makes your blood more likely to clot and stay clotted. So Lp(a) both accelerates plaque formation and makes you more likely to form a clot on top of that plaque. It's attacking you from 2 directions. And here's what makes this terrifying. About 20% of the population has elevated Lp(a), 1 in 5 people. Most of them have no idea because Lp(a) isn't part of standard cholesterol testing. Because doctors assume if they can't change it with diet advice, why bother testing for it? But that thinking is wrong, because even though you can't lower Lp(a) with diet, you can adjust the rest of your treatment based on knowing you have it. If you have high Lp(a), you need aggressive management of every other risk factor. Your LDL target should be lower. Your blood pressure target should be lower. You might need aspirin or other therapies. You might need more frequent monitoring. And there are new drugs in development that specifically lower Lp(a). Phase 3 trials are happening right now. Some of these drugs lower Lp(a) by 80 to 90%. If they work, and if they prevent heart attacks, they'll be available in the next few years, but only to people who know they have elevated Lp(a), only to people who've been tested. Harold's Lp(a) was 186 nmol/L. Anything over 75 nmol/L is considered elevated. Anything over 1 in 25 is high risk. Harold was in the danger zone. His father passed away at 58. his grandfather at 61. Harold almost joined them at 62. 3 generations, same genetic time bomb, and nobody tested for it until Harold was lying in a hospital bed with a stent in his chest. What should your LPA be? Under 75, NMOL is desirable. 75 to 125 NMOL at L is moderate risk. Over 125 NMOL is high risk. Over 200 NMOL is very high risk. Here's something important. You only need this test once because LPA is genetic. Your level stays essentially the same throughout your life. Diet doesn't change it. Exercise doesn't change it. Statins don't significantly change it. One test tells you what you need to know forever. At your next appointment, say these words: I'd like to check my lipoprotein A level. The American Heart Association recommends testing once in all adults to assess genetic cardiovascular risk. That's the language. That's the authority. That's how you get the test. It costs about $30 to $50. Insurance usually covers it, and you only need it once. Now let me address the objections because I know what you're thinking. First objection: my doctor says LDL cholesterol is fine. They've been measuring it for decades. It must be good enough. LDL cholesterol was a breakthrough in the 1960s. It was better than measuring nothing. It's not worthless, but it's incomplete. Measuring LDL cholesterol is like measuring the total weight of cargo on a highway and trying to predict traffic accidents. It's related to the problem, but it misses the number of vehicles. It misses whether those vehicles are damaged. It misses whether the drivers are high risk. ApoB, oxidized LDL, and LPA fill in those gaps. Half the people who have heart attacks have normal LDL cholesterol. Half. The standard test fails half the time. Would you fly on an airline whose safety inspections failed half the time? Second objection: if these tests were so important, wouldn't my doctor already order them? Medicine changes slowly, painfully slowly. The European Society of Cardiology recommended ApoB over LDL in 2019. The Canadian Cardiovascular Society made the same recommendation. The research has been building for 20 years. Yet most American doctors still don't order it because they learned LDL cholesterol in medical school, because insurance companies built their systems around LDL, because change takes a generation. Don't wait for your doctor to catch up. Ask for the tests yourself. Third objection: what's the point of knowing my LPA if I can't change it? You can't change the number, but you can change everything else. If your LPA is high, you know you're playing with a loaded deck. You know you need to be more aggressive with every modifiable risk factor. Lower LDL targets, tighter blood pressure control, no smoking whatsoever, possible aspirin therapy, and new drugs are coming. By knowing your LPA now, you'll be ready when they arrive. You'll be first in line for treatments that could add decades to your life. Not knowing doesn't protect you, it just keeps you ignorant while the damage accumulates. Before we continue, I need you to understand why I'm sharing this. I've operated on too many Harolds, too many people who did everything right, who ate the oatmeal, who walked the miles, who got their cholesterol checked every year, who trusted the numbers their doctors gave them, and then they had heart attacks anyway because the numbers were incomplete, because the tests were outdated, because nobody ran the 3 tests that would have shown the real danger. I can't operate on everyone. I can't be there when the widowmaker blocks and the heart stops. But I can tell you what I know. I can tell you what tests actually predict heart attacks. I can give you the words to say to your doctor. This is why I made this video. This is why I'm asking you to share it. Because someone you know, someone you love, is walking around right now with perfect cholesterol and an ApoB of 140, with normal LDL and oxidized particles building plaque, with a genetic LPA time bomb they don't know about. This video could save their life. Now let me give you the complete protocol. Exactly what to do, exactly what to ask for, exactly how to interpret the results. Step 1, get the 3 tests. At your next doctor's appointment, request these 3 additions to your standard lipid panel: Apolipoprotein B, oxidized LDL, lipoprotein A. Use this exact language. I'd like to add ApoB, oxidized LDL, and lipoprotein A to my lipid panel. Recent European and American cardiology guidelines recognize these as superior markers for cardiovascular risk assessment. I want a complete picture. If your doctor pushes back, say this. I understand standard testing has been the norm, but research shows that 50% of heart attack patients have normal LDL. These three tests identify risk that standard cholesterol misses. I'd like to know my numbers. Most doctors will order them. If yours refuses, find a different doctor or use a direct-to-consumer lab. These tests are available without a doctor's order for $100 to $150 total. Your life is worth more than that. Step 2. Understand your numbers. For ApoB, under 90 mg/dl is good for the general population. Under 80 if you have diabetes, high blood pressure, or family history. Under 70 if you have known heart disease. Under 60 for aggressive prevention. For oxidized LDL, under 60 UL is optimal, 60 to 80 is borderline, over 80 requires intervention. For lipoprotein A, under 75 nmol is desirable, 75 to 125 is moderate risk, over 125 is high risk, over 200 is very high risk. Step 3, if your numbers are elevated, take action. For high ApoB, your particle count is dangerous regardless of what your LDL shows. Discuss with your doctor whether statin therapy or other medications are appropriate. Reduce refined carbohydrates. Eliminate seed oils. Increase fiber to 30 grams daily. Consider adding plant sterols. For high oxidized LDL, your particles are damaged and inflammatory. Focus on antioxidants. Berries, leafy greens, pomegranate, olive oil. Eliminate seed oils completely. Go to your pantry right now. Look at every label. If it says soybean oil, canola oil, corn oil, sunflower oil, throw it away. Add omega-3 fatty acids from fish or supplements. Consider CoQ10 supplementation, especially if you're on a statin. Reduce sugar and refined carbohydrates aggressively. For high LPA, your genetic risk is elevated and won't change with lifestyle. Be aggressive with every other factor. Your ApoB target should be lower. Your blood pressure target should be lower. Discuss with your cardiologist whether aspirin or other interventions are appropriate. Ask about being considered for clinical trials of new LPA-lowering drugs. And absolutely test your family members, especially your children and siblings, because they may have inherited the same time bomb. Step 4, retest appropriately. ApoB and oxidized LDL should be retested every 3 to 6 months if you're making lifestyle changes or adjusting medication. Once stable, annual testing is appropriate. LPA only needs to be tested once. It's genetic. It doesn't change.